Assalamu alaikum wa rahmatullah. Thank you, Dr. Ahmed. So today I'll be presenting with my good friend and colleague, Dr. Qasim Al-Abri, the topic of TAVR versus SAVR for patients with a small aortic annulus or extreme sizes. Let's start with the case. So Mrs. B, she's a 74-year-old lady with history of asthma, comes into our clinic with symptoms of exertional dyspnea, atypical chest pain, and one episode of syncope or pre-syncope. Her symptoms started a few months before presentation. Her physical exam was suggestive of an aortic stenosis murmur. She had an ECG which showed a normal sinus rhythm with normal QRS and normal PR interval. Her transthoracic echo showed a hyperdynamic LV with an EF of 70% with concentric LV hypertrophy, severe LV dilatation. She had a tricuspid aortic valve with thickened leaflet and severe reduction of the cusp opening. Her aortic valve area was 0.79 with a mean gradient from 41 to 43 millimeter of mercury and moderate concomitant aortic regurg. She had mild MR again with thickened leaflets, mild to moderate TR with a pulmonary artery systolic pressure of 54 millimeter of mercury. So following her echo, we proceeded with a coronary angiogram, and she had normal coronaries. Now you have severe symptomatic, low surgical risk patient. Will anybody send this patient for surgery at this point in the room? Okay. So only one who will send her for surgery. Interesting, because actually if you follow the European guidelines, this is a surgical case. So a patient less than 75 years of age with low surgical risk, first line is surgery. Now the American says it's either surgery or TAVR, but the European is surgery. Anyway, in our practice, this patient will be evaluated for TAVR. So we proceeded with a CT TAVR protocol, and what you can see on the left-hand side of the screen, that there's not much calcium, and that follows the talk of Dr. Faisal, that we see, like in old females, little calcium and a lot of fibrosis. All these black islands are fibrosis. So this is fibrosis, and there's some calcium. And if you look at the annulus size, she has a parameter of 59.9 with an area of 273. So this is a very small annulus. And I am sure that if this lady goes for surgery, and this is the minimum diameter, so the minimum diameter is 16 and the maximum is 20. So if this lady goes for surgery, in most centers, I have to say, she will end up with a small surgical valve. Looking at the sinuses measurements, we have a 29, 26, 31, so it's a very generous sinuses. So at this point, anybody will send her for surgery with a small annulus? No? Okay, still for TAVR? Okay, but I think when we see these measurements, we are very concerned about PPM, either with surgery or with transcatheter option. And as we all know, like PPM, the door is opening, the door is functioning, but the door is too small for your need. And it's associated with increased cardiac mortality, reduced exercise tolerance, and quality of life, and structural valve deterioration. So what is the best option for these patients in terms of PPM risk? This is a nice editorial published by Philippe Pabarot from Quebec a few years ago, showing the incidence of PPM in patients with transcatheter valves and patients with surgical valves. And as you can see here, data from the partner trial, looking at the SAVR option, patient with severe PPM are in orange. There's 28% severe PPM in the SAVR group and 19.7% in the TAVR group. This is the randomized patient. Now, the followed-up non-randomized patients, it's around 13 to 15%. Looking at the core valve data, on the TAVR group, severe PPM was 7%, and on the SAVR group, 20%. And at the end, you can look at a meta-analysis, and the SAVR group is around 9.8%, and data from the STS TVT registry on the TAVR group, 12%. So we can see there's a big variability in the reported incidence of PPM. You have, it's anywhere between 7% in TAVR patients to 28%. So where's the reality, and why we have such a difference? There's a nice editorial published by Howard Herman in 2021, commenting on that. And he said that the reported incidence of severe PPM after TAVR varies depending on the method of gradient determination. Is it echo or cath? And the timing of it, was it done immediately post-procedure or on follow-up? And whether or not it was corrected for obesity. And the difference between echo and cath gradient were clearly and nicely delineated by Dr. Amr Abbas, when he found that there is almost 60% of patients has a pressure gradient different more than 5 millimeter of mercury between cath and echo immediately post-valve implantation. And around 10% of them have a pressure gradient difference more than 10 millimeter of mercury. And he attributed that to the pressure recovery and the using of the simplified Bernoulli equation. So now we're not sure, is it better to do surgery or to do TAVR in these cases? Now let's say the data suggesting a trend toward the favorability of transcatheter option. Is it a balloon expandable valve or a self-expandable valve? There's data from the STC ACC-TVT registry showing that severe PPM was reported in 5.3% of patients undergoing supraannular transcatheter options. And when that was compared in this paper between self-expandable valve and the core valve Evolut platform compared to a balloon expandable valve, the SAPIEN 3 or the SAPIEN XT platform, they found that the incidence of severe PPM was in fact lower with the self-expandable valve. It was 6.7% compared to 15.6% in the balloon expandable valve. So,
can we have more? 5 minutes,
5 minutes, please. So in this case, we actually decided to go with TAVR, and we implanted a self-expandable valve with the Evolut Pro Plus 23 valve. When we sized it was 20% oversized, and we intentionally deployed it low because we were afraid of the valve pop-up with the lack of calcium. Now, I'm not sure if it's right or wrong, but we had good results at the end. The echo post-procedure, 30 days post-procedure, showed a well-seated TAVR valve with a mean gradient of 7. And we have also an 18 months follow-up. The patient is completely asymptomatic, and she has a gradient in a single digit. Now we have recently, just last week, we have the published VIVA trial, which compared the TAVR versus SAVR in patients with a small annuli. And they defined small annuli with a mean diameter of less than 23, with a minimal diameter less than 21. So our case way smaller than that. And they were looking at the primary outcome of basically hemodynamics in terms of severe PPM and moderate to severe AR at 60 days. Interesting points on this trial is that we had more self-expandable valve, around 60% compared to balloon expandable valve, 40%. And in terms of the surgical arm, 20% of patients got a sutureless surgical valve, and 7% of them got aortic root enlargement. The primary outcome was not different between the two groups in terms of severe PPM or moderate AR, with a p-value that's non-significant. At 2 years follow-up, there was no difference in death, stroke, cardiac hospitalization, or the combined outcome. Now, there's also an ongoing trial called the SMART trial comparing the self-expandable platform to the balloon expandable platform in these patients with a small annuli. Thank you very much.
Thank you.